So, hello everyone. Thank you for joining us on this first session of our webinar series, ERAS and Obstetrics, so pain management and labor and delivery. So this is going to be recorded and posted on our website. We know it's tough to get onto webinars sometimes, but we are excited to kick off this series focused on improving pain management strategies for birthing patients while supporting recovery, patient satisfaction, and opioid stewardship. So we know that pain management is a critical part of maternity care and that every patient deserves to have their pain taken seriously and managed effectively. But we also know that this is a state where opioid medication and substance use disorder is very high and is one of the biggest contributing factors to maternal death. So we want to make sure that as healthcare providers and as community support, we have an opportunity to support recovery through evidence-based strategies that reduce opioid exposure, while still ensuring that patients are comfortable and supported and their needs are heard. So today's webinar is going to focus on the principles of enhanced recovery after surgery, or ERAS, and how these approaches can be applied in labor and delivery settings. We're going to discuss multimodal pain management strategies, explore non-pharmacologic approaches that can be used before, during, and after surgery or delivery, and talk about the important role that providers play in helping patients understand what to expect. So one of the most powerful tools that we have isn't medication, it really is communication. And so making sure to set realistic expectations, educate patients on options, and empower them to participate in their care and, talk and share can really have a meaningful impact on both pain experience and recovery outcomes. So a couple housekeeping items. Again, this webinar is being recorded and it's going to be shared after this session. So please share it with folks that you know may be interested but couldn't join. And submit questions through the chat throughout the presentation. We can help get folks' questions answered. So thank you for being here. And on behalf of March of Dimes and honor McDaniel Hill, who was unable to unfortunately make it today, we and the ALPQC, we are excited about your commitment to improving care for moms and babies. So with that, I will introduce our first speaker for the day, Dr. Judy Williams from USA, who is going to guide us through really the basic principles of ERAS. Dr. Williams is an associate professor at the University of South Alabama Department of OBGYN and a board-certified obstetrician gynecologist with more than 20 years of experience in private practice and hospital-based healthcare. Her clinical experience encompasses comprehensive obstetric and gynecologic care, including delivery, surgeries, and inpatient services across major hospital systems in Tennessee as well. Her past academic positions include teaching OBGYN residents and med students at Naval Medical Center, Portsmouth. My parents have a house in Chincoteague, so that's pretty cool. And the University of Tennessee Health Center, or Health Science Center, and she's held multiple physician leadership roles with the large Baptist Memorial Healthcare System in Memphis, with contributions to quality improvement, departmental operations, and medical staff governance. So I will pass it to you, Dr. Williams.
Thank you. And I'm going to share my screen, but somehow I managed to get through my life without having to screen share on a Zoom meeting. So this will be my first time. So forgive me if I mess this up. So let me know if you have any problems. Here we go. Can anybody see this yet?
Not quite.
No? Okay.
It's just the share bottom at the
yeah, I'm hitting the share button and then I worked on this morning. Is there someplace else I might find it? Okay, so at the top, oh goodness, I can't believe this is happening. So at the top it says share, and when I hit share, it only says get PowerPoint mobile app.
Oh, goodness. Let's see here.
How about can I send you the link? I'm so sorry, y'all.
Right. Yeah, send it on over to me in my email. I can
Okay.
put it in the chat if you'd like.
Okay.
And I can share it, and then you can just tell me when to move forward.
Okay, I'm really sorry. I was going to rehearse this first, and I did this on Zoom this morning, but I don't know why this is happening. So,
That's okay. I get the Zoom jitters as well. It's
okay.
Also, the way that Zoom decides to change things all the time.
I mean, I literally did this with my boyfriend this morning to make sure that it worked, and then of course it doesn't. So, I don't want to hold y'all up. So let me get to where I can send y'all email. Okay, Naomi, I just sent that to you.
Also, Dr. Williams, we saw that you all are getting a new MFM. This is very exciting.
We do, yeah, he's already here.
Is he?
Yes, Dr. Marr, very dry, very smart.
Excellent.
Yes.
Very making his way around the
Yeah.
Southeast.
Yeah, for sure. I mean, it's
Mhm.
nice to have, fresh set of eyes, ears, brain. All right, Naomi, did it come across?
yes, it did. It's
Okay.
just
Okay.
scanning it and
Okay.
downloading it. So it'll just be a minute more and then I'll share it.
Will I be able to control it though?
You may not be able to,
I'll just
but
say next
yep,
slide.
and I
Okay.
can do that.
Again, apologies, everybody. Okay, so obviously today we're talking about enhanced recovery in obstetrics, and all of this came from the concept of next slide, enhanced recovery after surgery. So this began with a colorectal surgeon, a Danish surgeon, who wondered why a 1 or 2 hour surgery required several days of recovery, sometimes up to a week. And the idea was that the body was in stress before, during, and after. So before in the fasting state, during obviously surgery being stressful, and then afterwards the recovery process. And so he developed a bundle of small steps that taken collectively would outperform any single change in recovery. And in 2018 to 2019, ACOG was brought that into obstetric guidelines too for both GYN and obstetrical surgeries. Next slide. So why does ERAS matter in obstetrics? Well, first of all, this is obviously one of the most common surgeries in the US, about 1 in 3 births. So you have quite a few women undergoing C-section, and there is a statistic of upwards of 1 in 300 of these opioid naive mothers may have persistent use after their C-section. And, where the patient who's a brand new mom doesn't even get to recover to rest. She recovers to care for the newborn. So you're not recovering the patient, you're recovering a parent who needs to be alert and mobile and able to bond with her baby from day one. Obviously, we know opioids can cross into the breast milk and reach the infant, so we don't want particularly sleepy, lethargic babies because that obviously inhibits breastfeeding and bonding. So the payoff for reducing opioid use and also just increasing patient satisfaction is you're going to get a faster recovery, greater bonding, greater breastfeeding experience, and a happy mom. Next slide. So the core principles of ERAS, as discussed earlier, are education, just setting expectations early. These are not the old days of, you have an appointment for surgery, you go get your surgery, you lie around and get pain medicine until it's time to go. Patients need to be aware that we have expectations that they are going to be, up and at them as soon as possible. And this also includes multimodal analgesia, the idea that opioids should be used as needed for breakthrough as opposed to scheduled dosage. And then you've got early nutrition, that's going to reduce your risk for ileus. Early mobility is going to reduce your risk for DVT. And then standardized care, making it an order set, nothing to opt into, but opt out of. Next slide. And I'm sure somebody else will touch on this, but there is some emerging evidence of using sort of a spinoff, enhanced recovery after birth. So using these principles, extending to women undergoing a vaginal birth, again, education, clear expectations, being mobile, hydrating, and then the early skin-to-skin contact, breastfeeding support. So you have, again, happier mom, happier baby. Next slide. So even though ERAS stands for enhanced recovery after surgery, it really begins before surgery. So before delivery, as discussed, we're going to talk about expectation setting for the patient, the importance of carbohydrate loading before surgery. That reduces the stress of the catabolic state in the patient for this prolonged fasting. And then medication optimization. And I think it's pretty standard to allow patients to take their routine medications with a sip of water, but just making sure that they still do that. And obviously infection prevention, which is huge in any hospital. Next slide. And then ERAS during cesarean delivery, it's pretty much standard of care for neuraxial anesthesia, general only under extenuating circumstances. Intrathecal morphine or Duramorph really is a cornerstone of pain management because you're giving these patients prolonged pain relief for about 24 hours after surgery. And then other things that we don't necessarily always think about, which is maintaining a normal body temperature, and then the things we do think about, which are obvious, like antiemetics, just keeping the patient comfortable. And then goal-directed fluid management. In other words, don't fluid overload them. And then, of course, delayed cord clamping. That obviously is for the baby, but if you have a patient who's undergoing a C-section and she gets the opportunity to have that baby on her chest for the first minute, particularly if you have a clear drape, then that starts the bonding process. So again, that's just one more step to increasing satisfaction to the mom. Next slide. So ERAS after delivery. Again, you're going for scheduled Tylenol, NSAIDs, particularly Toradol if the surgeon's not opposed to it, and doing that around the clock, not PRN, and really trying to reserve those opioids for breakthrough pain early. Only. And then, of course, early feeding, as we discussed, early ambulation, get that catheter out as soon as it's reasonable, and of course, breastfeeding support. I think that this hospital does a good job of breastfeeding support because it's repetitive. Making sure on a regular basis these patients feel supported, not just a one and done. Next slide. And then does ERAS really reduce opioid use? A good study out of the Green Journal in 2020 using very strict criteria for ERAS management showed, if you look at the right of the slide, you had 84% of patients requiring some opioids during their inpatient stay and only 24% after ERAS. And I think that that's an achievable goal. I don't think it's I don't think it's current, but I think it's achievable. So you are seeing a 30 to 60% reduction in patient opioid use. So less inpatient opioid use, presumably less outpatient opioid use. and again, improve patient satisfaction. We keep going back to that. And it's not just about patient satisfaction scores for the hospital, but overall, if a mom is happier, then, less postpartum depression and just overall having a generally favorable attitude towards the childbirth experience, even if she required a C-section. Next slide. So I'm probably older than most people on this Zoom, and maybe you don't remember this, but in the old days, it was strict NPO after midnight, absolutely nothing except maybe your medicine with a sip of water, going straight to opioids first. A lot of times a PCA pump. You didn't feed them until first day post-op. You didn't take out their catheter until first day post-op. So these are just standard orders. It was very rote. And then when you introduce ERAS into the equation, again, you're reducing that, you're narrowing that fasting window, trying to give them a carbohydrate load. And obviously, if you have a brittle insulin-dependent diabetic, that's going to be variable. But again, a multimodal opioid-sparing analgesia, the early feeding, the early mobility, and the standardized order sets that I keep talking about. Next slide. And so here's a good example of preoperative instructions, very clear to the patient what they can expect. You also need to, when it says up to 6 hours before you can have a light meal, you might define that to the patient. A light meal to them might be, a sausage biscuit because it's not a bunch of stuff, but obviously that's not very light. So just again, in education and clear expectations. Next slide. Implementing ERAS well. So the team, everybody on the team needs to be on the same page all the time. You can't have one who doesn't want to do something and everybody else want to do something. Everybody has to agree. So that's probably the biggest barrier to implementation of a full-on ERAS program. But you need to make it the default order sets that everybody approves of. And then after that, do an audit, measure the compliance, see if everybody's doing what is expected. And then lastly, minding the gap. You have to, as clinicians, we have to understand that there's going to be a gap of time between when we say we're going to do something and when it actually comes to pass. Next slide. So here at USA Health, Children's and Women's in Mobile, what we do, nearly 100% of the time, if the baby is, doing well, delayed cord clamping, skin to skin. Now, of course, in C-section, it's going to be, on the chest. But room for opportunity would come in the multimodal analgesia. I still see orders for scheduled opioids in post-op patients. And we see anesthesia still requiring the 8 hours of NPO. And it really depends on the anesthesiologist. We'll have some locum tenens who really don't do a lot of OB, who are just adamant that they're not going to be, they have to be 8 hours. So expanding the standardization so that everybody who comes and works at Children's and Women's understands that this is our protocol, we can better implement it. So there are areas of improvement here at South. And their last slide are my references. And that's it. Questions?
Thank you, Dr. Williams. Do folks have any questions? You're welcome to either come off mute or put something in the chat box.
Hi, Dr. Williams. I think I got to work with you once with a
Yes.
client, a doula client that I had at USA. I just have a question about how the NPO works for the mothers who are in labor. We as doulas, we encourage certainly clear fluids, but honestly, we encourage light snacks all throughout labor as well. Obviously, for someone who's in a high risk category, we wouldn't do that. But just curious about your
Right.
thoughts on that.
Okay, so I'm in Memphis, we let them eat in labor. Obviously, not cheeseburger and fries, but we let them eat light snacks, carbs, and clear liquids. I cannot get a straight answer on how strict they are here. Our nurse manager said just clear liquids is acceptable during labor. But I don't think anybody has, made it clear that it's okay to eat during labor. So I'm definitely pro that. I've only been here for just a few months, so I'm not sure I have the power to go and pound
Sure.
my fist, but anyway, I do
Right.
think it's something that we should move towards.
No,
Will
I
we be
appreciate
getting
that. I
a,
always tell my clients that typically hospital policy says you can't eat in labor, but they're not going to slap food out of your hands. So that's
Right,
kind of how I look at
exactly.
it.
Yeah,
Thank
exactly.
you. Thank you for answering that.
Sure.
hey, so sorry. This is Carrie Prince from DeKalb. Our firewall blocked, so we missed probably the first 15 minutes trying to figure how to get on. So we finally just jumped on during just on our phone. So will we be getting a copy of that recording as well?
Yes, there'll be recordings available.
Perfect. Will they just come to an email if we were signed up, or do we need to go somewhere to get them?
It should, however, I'll follow up with you. We will definitely have it on our website. So the Alpac website, I can throw that in the chat. And
Great.
once we have the recording, we'll post that there.
Thank you.
And then I don't know if Kat, did your question get answered? Related to diabetic patients? Okay, so we have a question in the chat, Dr. Williams, and it's what do you do for diabetic patients and fasting clear liquid versus apple juice before C-sections?
Here, they're probably going to be on a insulin loop before, and then then they should be able to have clear liquids in that 2 hour window prior. But they're pretty strict about, the insulin dependent diabetics being, their optimized blood glucose value before going back to surgery.
Awesome, thank you. Any other questions? Okay. Thank you, Dr. Williams. That was great. It was a lot of
Oh,
really good
you're
information.
welcome. And I'm so sorry for my IT ineptness. So
I don't know if it's inept so much as it's Zoom decides that it's going to sprinkle in a little extra spice just
yeah,
about every other day. And
sure.
that's not even counting the struggles that we run into with Teams.
All right.
Don't even get me started on Google Meet. So I think you're good.
Thanks.
No, we appreciate you taking the time. So next up, we have Tiffiny Moseley and Dr. Amanda Williams with Thomas Hospital. So they're going to be presenting on their experience implementing ERAS protocols and then the outcomes that they experienced in their own units. So Tiffiny Moseley serves as the Director of Women and Children's Services at Thomas Hospital. She spent 30 years in the hospital-based nursing, including 24 years at Thomas Hospital, during which she earned an MSN from the University of Alabama at Huntsville. While the majority of her career has been in labor and delivery, she developed a passion for patient safety while serving as a patient safety officer prior to moving into her current role. She holds certifications in inpatient obstetrics, as well as obstetric and neonatal quality and safety from the National Certification Corporation, and is committed to educating patients and staff about biological processes, supportive nursing care, error prevention, and health promotion. I'm hoping at that 25-year point, Tiffiny, you get some kind of a pen or a bookmark or something for your desk. So,
Right.
right. Dr. Amanda Williams serves as the perinatal and pediatric pharmacy services coordinator with the Infirmary Health System, overseeing clinical pharmacy services across neonatal, pediatric, and obstetrical care. She completed PGY1, and PGY2 critical care pharmacy residencies at the University of Virginia and bring more than 15 years of specialized experience in infant and pediatric pharmacotherapy. Dr. Williams is a dual board certified in pharmacology and pediatric pharmacotherapy through the Board of Pharmacy Specialties. So I will defer to you both, and we've really
Thank you, Britta.
wonder if
That
we
felt
get
like a
bingo
lot,
for the number of Dr. Williamses we get on one webinar.
right? I'm so excited about Dr. Judy Williams' presentation because I was just sitting here grinning the whole time thinking, oh my gosh, we really do that. And now I'm going to tell y'all what it looked like for us to implement that because it's actually pretty exciting to see it all come together. So we talked about what ERAS is. Are y'all seeing my screen?
Yes, it looks
Okay,
good.
just making sure. Amanda and I have nothing to disclose. So I wanted to kind of just remind everybody because I've been in hospitals for a long time and sometimes it feels like we're not getting anywhere, we're not getting anywhere. So how it went down here is that in 2019, we first had ERAS by some of our general surgeons for our colorectal surgeries was where they started and they became very popular. And so then in 2020, our obstetrician said, hey, we want to do that too. And then, there was also a pandemic. So some things didn't move real quickly. But in 2021, we finally had an order set because we had to collaborate with not only the OB docs, but also nursing pharmacy. And then IT had to build it all for us to be able to get to the place that we were going to be able to implement ERAS. Then we started trying to educate nursing because I know that sometimes I think of nurses as resistant learners. We can be. We like the way we've always done it and we don't want to change that. So we had to really focus on, hey, this is going to be better for our patients. They're not going to hurt as much. They're going to be up, they're going to be moving, they're going to be eating, and they're going to be able to get out of here. And it was kind of a hard sell initially. And it was even a hard sell for some of our physicians. We had some physicians that were super excited about starting this and other physicians that, well, to be truthful, we still have a physician who is not sold on this process as even today. But most of our physicians have let us come and drag them on in and participate in ERAS now. We also started just talking with the nurses about what the differences would look like. They were not quite ready to feed everybody. It took us a long time to convince everybody that really they could just go to regular food. But we're finally there. We encourage chewing gum. We get them up and out of that bed, dangling and ambulating that first day. Those were not things we did when they had a PCEA. So what do our meds look like? This is actually our present day meds, and I'm happy to share I've created, although it's not pretty because I had to take it from computer generated and then make a list. I'm happy to share with any facility that would like the medications that we use now, because I'm going to go through with y'all kind of how we got here. But this is our list of meds. Everybody routinely gets everything on the left-hand side. The pantoprazole.
Tiffany, really quick, the slides are not changing.
Uh-oh. Interesting. Oh, they're changing over here. Okay, well, hold on. This is why
There we go.
I wanted to be with Dr. William. That era. Yes. Okay, so we give all of the meds on the left-hand side, including Tylenol pre-op or acetaminophen. I know I'm supposed to use the right words and I don't because I'm a nurse and I'm sorry. So that's my disclosure that I'm not good at using the trade name with the generics when I should not. But we use all of those meds on the left-hand side routinely. We give all of those things to all of our patients unless there's a contraindication, of course. And then everything on the as needed side, including oxycodone, is only as needed. And if you look at our on the right-hand side, there's no IV meds on there for pain. We are not using IV narcotics in our patients after they deliver. We are not seeing a need for it. They are well controlled on this regimen. So that's been one of the things that's super exciting because, like Dr. Williams, I've been doing this a really long time. I do remember when we were taking care of OB patients exactly the way she presented in that way back slide. So this is a significant change for us when we talk about what they're getting. So how did the steps actually go down? Well, right before we even rolled the process out, we realized, oh, we've got the gabapentin on here to be given TID. Well, TID here would have been at 9 a.m., at 1 p.m., and at 5 p.m. So the patients would have been getting 3 doses of gabapentin in that one window of day shift, and then they'd have gone all night without anything. So it's just a process of, ooh, we need to fix that. Then we thought, okay, well, when are we going to take their IV out? And while we decreased the fluids already, we were still leaving an IV access port. And then after a couple of situations, we thought it would be better if we left it until we have the H&H the next day so that we don't have to worry about resticking a patient if they were to need a transfusion or if they were to need further medications. So that became a process. Then we started having physicians order the Claritin for pre-op as pre-op for itching. And as they saw that that seemed to help, that became a part of our order set. And then we've gone through several changes with our scopolamine patch. Initially, we put that on and left it for 72 hours. Then we went down to 24 hours. Then a while later after that, we went down to 12 hours because we realized we could get the maximum benefit with a minimum impact on lactogenesis. Our lactation team is actually who came to us with that one and said, hey, could we take it off at 12 hours instead? And then we've had to build a process around how do you make sure that a medication patch gets removed? Because that turned out to be a little harder in our world than we thought that it would be. But we now have a process so that the nurses can document when they remove that patch. And so that piece can get done as well. And then the last change, just to kind of show you that changes come from lots of different sources. You know, pharmacy caught the med things, then nursing asked about leaving the IV in, then lactation asked about changing the scopolamine, and then our anesthesia team presented to the whole hospital steering committee of they would like to give 1,000 of acetaminophen before every surgery. And why not include OB with that too? If we're going to do it for everybody coming in for surgery downstairs, why would we not include it for the OB patients? So we added that to our pre-op regimen. Next up, I just wanted to give kind of a real life example of something that a problem you have and then how you solve it. Because we had a lot of miscommunication initially. Our anesthesia team converted to ERAS faster than our obstetrician team in some cases. And so the anesthesia team was all like, oh, this works great. And then there was a miscommunication between the physicians who would think that their patient was going to have a PCEA after surgery and have push button. And that's what they've talked about. And then they miscommunicate with anesthesia. Anesthesia's putting them on ERAS. Or vice versa. We did have it happen both ways, that the anesthesiologist thought that doctor wanted to stick with a PCEA, so they didn't proceed down the ERAS pathway. And ultimately, the solution to this came from the nurses at the bedside who said, can't we just ask at timeout? Can we just say, are we doing ERAS or a PCEA? And sure enough, that got everybody understanding exactly what was going to happen right from the beginning of the procedure, so that you knew which pathway we were going to proceed down. I'm going to hand off now to Dr. Williams, and she will share what the results of all that look like, because that's where it gets really exciting.
Okay, I'm trying to make one quick change to my slides here because we are not in presenter mode. Okay, we'll just carry on with it like it is.
It looks
okay.
from our end, just so you know. It looks like you're in presenter mode from here.
Okay. Our slides aren't changing
confusing
on
with
one screen. Okay, so I am presenting today the results from one of our pharmacy resident research projects. This was done by Trace Easterling. He's a current PGY1 pharmacy resident who's about to finish up. He is primarily at Mobile Infirmary, but this project encompassed all three of our facilities, Thomas Hospital and North Baldwin included as well. The purpose of the project was to compare opioid utilization in patients undergoing cesarean delivery with and without use of what we called the ERAC protocol, so enhanced recovery after cesarean. All right, the setup of the study was a retrospective chart review between January and July of 2025. We looked at 150 patients in each group across all three of the hospitals. And just note, at this time, Thomas Hospital was the only facility using ERAC, and that was done on the majority of the patients having cesarean deliveries at Thomas Hospital. So most of your non-ERAC patients were coming from Mobile Infirmary and North Baldwin. We included patients who were greater than 18 years of age.
had a cesarean delivery between those dates. We excluded anyone who obviously was younger than that age, if they had missing chart data, or if they had complications that would have increased their opioid use or length of stay, examples being uterine rupture and peripartum cardiomyopathy. All right, primary endpoint was the difference in what we'll call MMEs, or morphine milligram equivalents. So you take all of your opioids and convert them to an equivalent dose of morphine for ease of comparison. We compared that between our ERAC and non-ERAC groups. Secondary outcomes included the difference in average daily pain scores, inpatient use of naloxone, looking for adverse drug events, length of hospital stay and urinary catheterization post-cesarean delivery, and then also our discharge opioid prescription MMEs. So quite similar to the study that Dr. Williams mentioned earlier. Baseline characteristics, we had 317 individual patient charts reviewed, 145 in the ERAC group and 158 in the non-ERAC group. 10 patients were excluded in total. The median maternal age was roughly 30. Make sure these slides are changing. Okay. About 50% of our patients had a scheduled cesarean delivery, and about 50% also had a primary C-section. When we look at intraoperative pain control, you can see that the non-ERAC group had more use of spinals, whereas you saw a lot more epidurals in the ERAC group. Of note, though, the overwhelming majority of these patients all received the Duramorph, or the morphine, through those routes. And then if we look at opioid prescribed at discharge, you can see that over 90% of patients did receive an opioid prescription at discharge. Looking at our primary endpoint, you can see here on the box and whisker plot, comparing the blue, the non-ERAC group, and the gray is the ERAC group. So our median MMEs in the non-ERAC group was 86.3 versus 22.5 MMEs in the ERAC group. That was statistically significant. You can also see that the max MME, which is the top of the gray box, was about 90 in the ERAC group, which is pretty close to the median MME in the non-ERAC group. So a substantial reduction was seen there. In regards to some of our secondary outcomes, we looked at Foley catheter removal times, time to need for a first PRN opioid, and then length of stay. And we saw improvements in all three of those that were statistically significant as well, with a 12-hour reduction in length of stay seen between the two groups. And then median pain scores were also statistically significantly less in our ERAC group as well. Then focusing on those discharge prescriptions, we did see a 50% reduction in discharge MMEs. However, you'll note that compared to what the patients were receiving inpatient, they went home with probably more than they may have received post-op while they were in the hospital. So this is definitely an area that we are looking on, and I'll touch again on that in a minute. But just to make this make sense with some actual medication numbers, 225 MMEs, which is the median for the non-ERAC group, is roughly 20 hydrocodone 10 tablets, 15 oxycodone 10 tablets, or 30 oxycodone 5 milligram tablets. So we found in our study that our patients that received ERAC had fewer inpatient opioids, shorter length of stay, and lower pain scores. And then we also saw at discharge that we had use of opioid prescribing was lower on average between the ERAC and non-ERAC groups, but that is an area for improvement. So our ERAC protocol reduced inpatient opioid requirements, improved pain control, and accelerated recovery timelines following cesarean delivery. Our future directions from this study include looking at those discharge opioids, and a couple of updates that we have that are relatively new in the last week or so. We are looking at adding an MME calculator that will show up. It currently is available on the inpatient side when opioids are ordered, and it shows MMEs ordered in the last 24 and 48 hours and MMEs charted as given in the last 24 and 48 hours. So we're looking at having that added over to the discharge prescription side of things as well, so that the providers can actually see how much their patients have been receiving and maybe adjust those discharge quantities. And we are also pulling a list of the default quantities that are in the OB's favorites for their opioid discharge scripts as well, just to see if maybe this is habit that's defaulting in and we need to adjust some of those defaults as well. So that sums up what I had to share. I'll let Tiffany talk about our last picture.
Yeah, this is my second daughter having my first grandson, and I was privileged to be in the room. This all went down in March of 2021. So it really drove home the need for me to look at enhanced recovery after cesarean, because there we are. So my daughter ate a turkey sandwich in the recovery room because her physician was a quick adopter of some of the practices of ERAS. So while we didn't have everything we have today, I think that she still remembers that, being, hey, I can get back to normal. That was probably the thing that empowered her the most, was being able to start with regular food. And then it was certainly a relief to me that we could start demedicalizing birth as quickly as possible to get her home with that precious baby boy.
Do y'all have any questions?
I have one. So you said that they usually use Duramore in the spinals.
Yes.
Do y'all feel like that controls their pain better afterwards, since having that versus the traditional medications?
We definitely do. It definitely, from an anecdotal standpoint on the nursing side, it took a while, but then everyone really was hoping that their patient would come out on the ERAS protocol. But then when Trace actually looked at these numbers, it definitely makes a difference. The patients themselves report dramatically less pain than they did. And we've had a number of patients who have had deliveries both ways now. They've had a C-section and had the PCEA, and then they've had a subsequent one and had the ERAS protocol, and they're very, very pleased, by far and away the majority.
That was my experience as well. So I was just curious if it was the same way there. So thank y'all.
Yes, ma'am. I was wondering the length of stay that you guys are experiencing now. Here we do sometimes do Duramorph. It just depends on the physician for the day, but how long are your patients staying now? Because ours always go home in 48 hours unless there is some type of medical issue that requires them to stay past that point.
So our patients have the option to stay 96 hours.
Correct.
And they, and some of them, really want that because that is their expectation and what they want. But traditionally, our doctors have done a 72-hour discharge. And so we have decreased not a ton from that, but from 75 to 63 on this is what our data shows. I did pull the Thomas specific data this morning, and it is very close to that as well. We have not changed that length of stay dramatically, and I don't expect that we can change it too much more than that, simply because of the fact that, we do have the legal requirement that they can stay 96 hours if they choose to do so, and that's going to impact that. But we certainly have the ability to say, to those moms who are 48 hours out and want to go home and feel well controlled on oral medications, that if that's in agreement with their doctor, they can do so.
Okay, I just kind of wondered if it was like, typical, hours. We'll always go in and talk to them about going home kind of that first day. And, they know they can go home they know they can stay extra. Typically ours won't. We have a few that want to stay, but they want to get home to their families. But I just kind of wondered if it had went down more from this or if this was like your latest.
No, I don't really anticipate it going down a lot more with our population. Our physicians are very comfortable, encouraging their patients to consider a 3-day stay. So those that, 2 we really think of as early when they're going home in 2 days.
And have you noticed a huge difference with the Tylenol PO? I know sometimes our docs will do Tylenol IV instead before we go back, but I've never gotten an order for Tylenol PO. So that was very interesting to me to add that.
Yeah, I'll take this one. I think from a pharmacokinetic standpoint, as long as you're getting that Tylenol oral in at least an hour before the procedure starts, there's really no benefit to IV Tylenol. And while IV Tylenol is not nearly as expensive as it used to be, it is still exponentially more expensive than oral Tylenol. And I will also mention that while our groups were ERAC versus non-ERAC, a lot of our mobile infirmary non-ERAC patients did receive Duromorph. So I wouldn't necessarily say that this is a comparison of patients who got Duromorph and patients who didn't get Duromorph. You're seeing benefits despite both groups primarily receiving Duromorph, but one group is receiving all of these ancillary medications like the Tylenol, the gabapentin, the scheduled NSAIDs, and all of those things as well.
Thank you.
Any other questions from folks?
The Claritin that y'all added to your pre-op meds, it helped with the itching that they would get?
Yes.
Okay. I thought that was interesting because I've never given Claritin for itching. Usually it would be something IV narcotic. So I love that.
We were really trying to find something that we've tried to make an oral agents, as much as possible. And then that Claritin is pre-op, and then they typically aren't going to get any more of that, but we have found it to be very effective.
And it'll have less impact on lactogenesis than something like Benadryl.
Yeah, and it's not going to make them as sleepy.
Yeah, try that.
Afterwards when they have to take care of a child. So that's great.
Thank y'all.
Oh, hold on. Kat said it sounds like some of the changes change with staff and provider recommendations, and wanted to know if they're all supported by evidence.
Yes. Yes, all the changes do also have to be evidence-based, but we definitely, want the staff, when the staff sees a better way, we like to look at whether or not that would also be better for the patient.
So that being said, I have a question of how are you changing physician physician practices in terms of new recommendations and things of that nature? Nobody's gonna get tired of me asking this question, but how are you convincing the doctors to make a change?
So the whole idea behind this research project was to make this a system-wide, because as I mentioned at the time that the project idea was born, we were not doing ERAC at 2 of our facilities. One of the things that I will say helped was the Blue Center for Distinction from Blue Cross Blue Shield. There is verbiage in there about using an ERAC protocol. And so that got some conversation started at our other 2 facilities. And actually prior to completion of the study, we have rolled both Mobile Infirmary and North Baldwin over successfully to ERAC protocols. That went through physicians committees and got blessings. And then we've also taken this center specific data back to all of those committees so they can see the difference that it makes. Follow up to this will also be looking again at this data to ensure that the order sets are being used and we're actually following ERAC protocol on those patients. We documented very high adherence here at Thomas, but we'll need to check in on our other 2 facilities as well. So I think providing them actual numbers from their patient population speaks volumes to them.
Awesome, thank you.
We were also lucky enough that a little bit of peer pressure went a long way in that, let's say there's doctors A, B, C, and D, and A, B, and C have all switched to ERAC and D hasn't, and D's patient delivers, but is delivered by Dr. B. And so they implement the ERAC protocol and then the patient reports a great experience. So, we had the gift of that because our obstetricians are primarily in 2 groups. So once they saw their partner's patient successes, they were pretty easy to convert.
And I would like to say something. I'm now in my car. So I know I'm supposed to only be speaking to my experience at Children's and Women's, but in Memphis, I had two major hospital systems I worked for. We did 100% ERAS, probably as of 2020, and including the Pepsid and all the things that she talked about. And it was a marked difference, and the physicians were not even given a choice. I mean, it was just like, here it is. This is what we're going to do, and there were no barriers at that time. So anyway, I'm just speaking anecdotally. It made a massive difference. Patients were the vast majority were going home 48 hours after a C-section. Obviously at Children's and Women's, we have a lot of like social issues or high acuity that keep them in the hospital longer. But you had a very rare patient that wanted to stay 72 hours in Memphis. I'm just saying it works.
That's awesome. Thank you. Yeah, USA or another hospital, I think any of these best practices are great to learn about. Amanda, did you have anything?
Yeah, I'm going to ask one more thing. At the beginning of the project, I know it's a little bit different, the ERAS and the ERAC. Did y'all use any of the studies that like general surgeons using the ERAS with abdominal surgeries and how successful that was on recovery outcomes to try to convince them?
So I don't actually have the answer to that question because it was one of our obstetricians who kind of drove that here. But I know she was aware of a lot of the studies that had been done with the general surgery. So I would suspect that was where she got her start, but I don't know.
Yeah, I worked on a GI surgery floor, and we had transferred over into doing ERAS. And, even without the data and all that, you could just see the difference that it made getting those patients up early and letting them eat and that type of thing. So I was just wondering if that was utilized as well.
Any other questions? Okay, excuse me. Afternoon. All right. Sorry, Jennifer. Last but not least, we've got Jennifer Krieger, who will be going over non-pharmacologic methods for labor and patient-centered care. Jennifer is a doula and childbirth educator in Mobile and Baldwin counties. She attends most of her client births in the hospitals and teaches birth classes privately as well as in groups. She has been a nurse since 1993 and has worked in the fertility field and in pediatrics, newborn nursery, and mother-baby as a hospital staff nurse. Jennifer started doing doula work in 2011 and made it her full-time career at the end of 2016. She especially enjoys the education aspect of doula work, assisting her clients in informed decision-making, and working with the other birth team members to help her clients achieve a birth in which they feel empowered. Personally, Jennifer has been married to her college sweetheart for 32 years and has 3 grown boys and 2 grandsons who have completely stolen her heart. Jennifer, this is adorable. She's especially grateful to God for guiding her in her journey through birth work and for blessing her with her amazing family, which sounds like it is full of boys.
Yes, boys indeed. I don't know if I would know what to do with a girl. That's how I feel about it. Thank you. I appreciate it. Thank you, Tiffany, too, for thinking of me to do this. So non-pharmacological comfort measures for labor and beyond. This also extends, of course, into the postpartum period as well. Just so you kind of have an idea of what my practice looks like. I typically teach about 6 or so full birth class series every year. Then I do private sessions and a couple of refresher courses as well. And I anywhere from 25 to 30 doula clients in any given year. 90 to 95% are hospital births. I do occasionally get to attend a community birth, and it's always a treat for me. But about half of those first-time moms, we end up going to the hospital anyway because we're exhausted or need some pain relief. So that's kind of what my practice looks like. I want to start with a little cartoon. 2 of my sons are very artistic. So I said artistic, lean a little more to the other side as well. If all of our moms could have spontaneous labor, I think that would probably help in supporting them in non-pharmacological means for getting through labor, but I know that doesn't always happen. This is a little cartoon I thought of when I was pregnant with my third son, and there's a little periscope sticking up through the belly button there to Junior weighs his options to see if it's time to come yet or not. I do have some learning objectives listed here. I'm not going to go through all of those. Those will be available to look at later. So speaking specifically about the postpartum period, if we can have better birth experiences, that's going to help with lower opioid use in the postpartum period as well. So fewer cesarean births. I know there are some initiatives in the state right now. Many hospitals are participating in to lower the primary C-section rate, which is amazing. If there's anything we can do to have shorter labors, to have fewer perinatal tears, better breastfeeding experiences, these are all the things that are going to help to limit that use in the postpartum period as well. I would be remiss if I did not mention utilizing doulas where they are available. We do have research to show the C-section rates are lower when there is a doula as part of the birth team. Lower use of epidurals. Mothers report higher satisfaction with their birth experiences. Also, we have higher breastfeeding initiation rates. Just so you can kind of have an idea what that looks like for my stats, 234 births to date. That actually needs to change because I did have a birth this morning. So it would be 235 births. Just as a shout out to her, this was a completely unmedicated hospital birth, and this baby weighed 1014. So this was a new record for my doula clients. It was very exciting, and she did an amazing job. If you look all the way back from 2011 when I started, 17% C-section rate, but I just went back to 2023, you know, COVID, some of those numbers look kind of funky during COVID. But for the last 3.5 years, my overall C-section rate is 10%, 88% VBAC success rate, 95% for moms who go into spontaneous labor with VBACs, and overall 45% epidural rate for my clients. For first-time moms, it's 65%. So I like to look at those numbers. I have put the non-pharmacological comfort measure into 3 basic categories. And to me, this is the order of importance. Environment, there are some things we can do to set their environment, both emotional and physical. Movement, specifically freedom of movement, is going to be key for a mom making it through without pain medication and labor. And then hands-on support. A lot of people, when they hear about doulas, what they picture is the massages and the hip squeezes and things like that, which is a part of what we do. But I feel like these other things are often a bigger part of what we do. So setting the emotional environment, let's lower the fear factor. What we teach in the childbirth education space is the fear intention cycle versus the safety peace cycle. So the fear intention cycle basically is that a mother who is fearful is going to hold tension in her body. So she's put herself into a fight or flight mode. So she's going to have more tension there. She has adrenaline circling through her hormones rather than oxytocin, and that directly competes with oxytocin receptor sites. So labor can be longer, pain can be worse, all those things. So the opposite of that is if we can help get them into the safety peace cycle, which is where a mom feels, she feels like she's in a private space. Her birth team is all there. She can focus back to her hindbrain, kind of get in touch with her instincts more so. The oxytocin is releasing, so she's got endorphins releasing in response to that, and labor can continue and pain is lower. So that is our goal in helping to set up the emotional environment for these mothers. Nursing education, a good pep talk goes a long way. I have seen this personally when I come into the hospital with my clients. If her nurse gives her a quick pep talk, it really does help. If she comes in with a birth plan, read it, tell her that you've read it, and then as long as she and baby are doing okay, you're going to help her to reach her goals. If she doesn't have a birth plan, ask her what her goals are. And, more specifically than a healthy baby, does she have other goals as well? A quick review of her rights in childbirth. National Partnership for Women has a great document on this, and that is the first list of sources at the end of my presentation as well. So good place to look at that. Let her know she's in the driver's seat here. She has the right to informed consent and informed refusal And if she is asked to make a decision and is not given enough information, let her know she needs to ask more questions. And then as long as it's not an emergency, she has time to think about it, to talk about it with the people who are part of her birth team. I think a big part of this too is acknowledging that what she is experiencing is normal, especially for a first time birther who has not gone through this before. It can all be overwhelming. And especially if she did not prep herself with birth education before, she doesn't know whether or not this is normal. So especially for those of you who see this all the time or have experienced an unmedicated birth yourself, let her know this is normal. And of course, we know there's some pain in labor that is not normal. When you see the mother who is disassociating from her pain, you know, that person's going to need a little more than just the comfort measures that I'm talking about typically. Give a quick breathing tutorial. The breath work is, to me, their first go-to for handling the strength of their contractions. And this is what I teach in my classes, is the slow belly breathing. We release our belly when we inhale, not our chest wall. We breathe in for 4, out for 6. I talk about blobbing. I want them to drop their shoulders, let their lower jaw release. And as they inhale for 4 and let their belly expand, and when they exhale, I want them to picture their breath going down to their baby and come back up in a J shape, because this is the motion we want baby to take, to come down and out and up. So just for kicks and grins, and because we can all use a little extra slow breathing in our life, I'm going to actually show you where I'm going to go through 2 breaths. And if those of you who feel like participating, great. I want hands on belly to start. I want shoulders relaxed, lower jaw released, eyes closed. And I'm going to talk you through the inhale. So we're going to inhale, 2, 3, 4, and down. 2, 3, 4, 5, 6. One more. In, 2, 3, 4, and down. 2, 3, 4, 5, 6. I need to do that more often in my life. How about our physical environment? What can we do? Promote privacy is a big part of this. As soon as we can get those lights down low, I'm turning the lights off in that room. I'm keeping the curtain pulled between mother and the hallway. So if the door opens, she's not thinking about who is in the hallway, you know, visitors or whoever who might see her in there. I encourage her to wear her own clothing, her own gown. If she feels better being naked, fine. That's going to keep extra people out of the room, right? So we want to keep it as private as possible. I encourage my clients to keep their undies on as well. And I know that when they come into the hospital, they're going to need to have a cervical exam done to see whether or not she needs to stay, to see if we need to get a doctor in quick. But if we're not close to having a baby, you know, especially for the inductions, she could be 24, 48 hours before that baby comes out. And she's going to feel a lot more private if she can keep her underwear on. So I encourage that for sure. I like to set up a labor cave in the bathroom. So I bring little LED candles in there. So the lights are off in the bathroom. And I always tell them that if they're feeling overwhelmed at any point, go hang out in the bathroom for a little bit. Sit on the toilet. Our toilets have these awesome warm seats now in the labor units. They feel amazing. Take your phone in there with some music, or get in the shower and take a candlelight shower. There's a lot of progress that happens in that space because it's so private. She's not worrying about who's walking in or who is watching her. But we talk about flooding the senses with pleasant things to interrupt the pain senses that are coming from the contractions. We actually have research to show essential oils in labor result in lower pain scores in labor through all stages of labor. The oils that have been studied include lavender, bitter orange, jasmine, rose. If any of you are in the essential oil space at all, you know rose is really expensive. Jasmine is kind of up there too, but just so you know, Young Living has a blend called Gentle Baby that has rose and jasmine and lavender in it, and you can get a little bottle for 25 bucks. So I keep that in my bag, and for moms who like it, we will diffuse that. But the ones I use the most often are lavender, orange, and peppermint. Lavender is just great in that diffuser just to keep things calm, especially for someone who maybe struggles with extra anxiety. The orange great if we're extra tired, just need a little boost or right before we're ready to start pushing. And the peppermint, of course, works great for the nausea. I will put a little wad of toilet paper in the bottom of an emesis bag, drop a couple of drops of peppermint on there so she can hold it, smell it anytime she wants. And if she needs to throw up, then the bag's already there. So that works out great too. I always encourage them to. Throwing up is not a bad thing in labor. It's a great way to bring a baby down if we're that close. What are they tasting? So I referred to this a little bit earlier with Dr. Judy Williams' presentation. It's really important that they have some calories in their system while they are laboring because their body needs the fuel. If they are lacking in calories, if they are lacking in hydration, we know that can result in longer labors and higher C-section rates. So I encourage them to drink some carbohydrate drinks, and I'm going to encourage them to snack, truth be told. Not big meals because those are probably going to come back up, but that helps to keep the pain lower. And it also helps to shorten the labor a little bit because our body has the fuel that it needs to do it. We have study on music in labor, lower pain scores in labor as well for that. So I encourage music. They might have affirmations, maybe some written out affirmations that they want someone in their birth team to read to them, or affirmation tracks like Hypno Babies. Christian Hypnobirthing has a great app with this that I have personally witnessed clients who I watched them before and after they started listening to it in their labor process. And I was even surprised at what a difference it made. And that app also has a built-in contraction timer. So it's a really good resource for them. Lights that we like to set up in the room, parents may bring in their own things, a set of Christmas lights, or USA Children's and Women's here has a comfort labor cart that they have put together for their patients that has little galaxy lights on it. I don't think they have the LED candles, but that's what I bring. They also have combs that they can hold in their hands to help send the different pain signals. Different things. They have lavender sticks that they can smell too. So that's an idea. I just like having some distractions like that. You might have a baby item set up where a mom can look at that baby item. Sometimes I'll take the little diaper that's on the warmer in the room and I'll put it where they can see it or shine the spotlight from the warmer on it. Helps to keep them focus their eyes on the prize. And I also encourage the use of the shower or tub too. If I have someone who doesn't want an epidural and she starts thinking she wants it or starts expressing that she wants it, if I can get her into the shower, that typically buys me an hour or more because it really does make a big difference. And they don't believe it's going to help that much, but it really does. But the same thing with cold packs or hot packs for the lower back. These are things that can help to distract them from what they are dealing with. How about movement? In labor, movement is key. This is where all of our props come into play. So I tell my students when they get to the hospital to ask their nurse to bring in all the things. Bring in a squat bar, bring in a birthing ball, bring in a peanut ball. I always suggest they have their birthing ball in their car so that if the right size is not available or in use, that they can go out and get theirs. They don't know what they're going to want in labor until the laboring process is underway. And they may just see that prop in there and decide they want to try it, and it can make a big difference. Of course, utilize intermittent monitoring or wireless monitoring for those moms who have inductions underway. Saline lock the IV if it's not an induction, but she has to drink if she's not going to have IV fluids going, because that is important for keeping her labor going. My aim is always to encourage them to get 8 ounces every hour while they're awake of whatever it is that they are drinking. And then I always teach too, it's not rocket science. We're just going to alternate positions every 20 minutes or so. When they're home, if they can stay at home in early labor, that's a big part of helping them make it through this. But, we have more and more moms who are being induced, especially since 39-week elective inductions are promoted a little more now. So it's important that they keep changing it up. I do want them to rest in early labor as much as they can, because by the time they get to active labor, lying down is going to feel terrible. And I just tell them that ahead of time. So lie down earlier in labor so you can stand and sit and do the other things later in labor. I do have a client who agreed to be my model, and USA let me use a labor room to take some pictures. This is Emily, and her husband thought she was crazy for doing this, but she's really excited because this gave her a preview of what her labor experience might be like there. So some standing positions to start with. And I know those of you who work labor and delivery, none of this is going to be new to you, but maybe you'll see one thing you hadn't thought of before. One of the first things I do when I get there with clients is I raise the bed up as high as I can get it so they can stand and lean over it. In that picture on the left, I have a rebozo. Of course, you could use a sheet or something like that attached to the handlebar on the opposite side. And I do find that a lot of moms like to reach for things when they're in labor, so they can, wrap their hands around the rebozo and pull. They can lean back and do some stretches. Same thing with that squat bar at the foot of the bed. I do have some who like to stand and hold the squat bar. Of course, you could take the foot of the bed off and put a rebozo from that, sit on a ball, maybe have something to hang from. I wish we could hang some slings from the ceilings in our hospitals, but no one's quite there yet, right? Maybe someday I can dream. But other standing things, standing in the shower is fantastic. Slow dancing, standing and lifting the belly up can help to make things feel better. Sitting positions, I really like the handlebars that are at the foot of the bed, because especially if we're in early labor and we've got a baby that's high, if we can sit on a ball and do really big hip circles, that helps to open the top of the pelvis. And so if they have something to hang on to there, that makes it easier for them to do. And of course, that Taylor sitting position on the right as well is great for opening the top of the pelvis. Other ways that we can sit in labor and utilize that squat bar. I love the peanut ball here. If I have a mom who is unmedicated and really tired, if we can sit in the bed like that, picture on the right, and we'll just prop a peanut ball up under her knee, it helps to keep things open and she can snooze a little bit. It doesn't, I have found, and especially in the spontaneous labors, that if a laboring mom is especially tired, her contractions will actually space out a little bit so she can sleep. They'll space out to every 7 or 8 minutes, and she may get 3 naps in a row in between contractions, and that often is enough to give her body the energy again that it needs. But I like using the peanut balls for that. And of course, sitting in the shower on a ball is also a great option, and sitting on the toilet, in the birth world, we call that the dilation station. I have discovered that most moms are either going to love it or they're going to hate it. There's not a whole lot of in between. They hate it because it feels more intense because everything opens up, but some really love it. So I encourage them to try a couple of contractions in their labor cave sitting on their toilet. Of course, kneeling over the back of the bed works great too. Babies' heart rates typically do better in this position when moms are upright. You kneel at the foot of the bed. You can kneel at the foot of the bed with a peanut ball as a prop if we're needing to be a little bit more upright. I also like putting the birth balls in the showers and have her kneel in the shower. And you can put a rolled up towel up underneath her knees for comfort. And then if we've got a removable shower wand, if their labor partner can stand there and hold that over the low back, that helps a lot too. And of course, lying down positions. These are going to feel terrible if there are no pain meds on board. But I have had a couple who, we had a baby who was still sitting up high and they wanted to try this. So this is Flying Cowgirl. So we've got an arch in the back here, peanut ball between the knees. Alpac, shout out to them, paid for Spinning Babies to come to Mobile this week. And I got to go on Tuesday to refresh. It had been 7 years since I had been to their foundational workshop. And I had already taken this picture, and now I know I've got something wrong in this picture, which I didn't realize, that her upper arm needs to be behind her to keep that pelvis open, or at the minimum, resting on top of that top thigh. Because if she's closing up the front, then that kind of closes up that space again. And so that was a great refresher for me to see that. So this is great for a high baby. Of course, traditional peanut ball. This is when we all first got peanut balls and we're like, I don't know, stick it between her knees. And it worked because it keeps those knees out and those ankles together and helps to bring a high baby down, gives them space to get into that mid pelvis. This is runner's lunge. This works greater for a baby who is already mid pelvis. We keep those legs kind of parallel to each other. What if there is an epidural in place? What can we do to help things move along faster? Here's my protocol, what I do. We rotate every 30 minutes while awake. If she needs to get some sleep, I'm not letting her go longer than an hour without changing positions. Typically what I do is we do one side, then the opposite side, then we're going to sit up and throne, and we're going to repeat that. If she has enough movement and we need it, we'll throw hands and knees in there because we need a little extra help to get her that way, and she needs to have more movement available for that. But keeping up on this does help it to go faster. Of course, use the peanut ball, and we can even do like an extreme side lying with a leg up in a stirrup on the side. That works great for babies who need to rotate. Pushing positions to help shorten things. Love pushing on the side. We want positions where our tailbone can move, right? Love the props. So this is great for moms who have epidurals as well. This is usually where we start, is pushing on the side so that that tailbone is not closed up. You can push with a peanut ball between your knees too. And I do have those who really like being able to reach onto something and hold onto something. If you have the peanut ball between the knees and bring their knees up, it's kind of like they're in a squat already. Creates a lot of space for that baby to come through. Of course, pushing at the foot of the bed, pushing over the back of the bed. If we need some extra space there, doing a squat helps to change the diameter of that mid pelvis as well. If any of you have not gone to spinning babies yet, do it when you have the opportunity. Even if you have to pay for it, it is worth it. It really is a game changer. You'll see some really good results from doing that with your own patients. And of course, even with epidurals, these are pushing options as well, using that squat bar. And then that picture on the right with the rebozo, it's just an alternative way to do tug of war that helps to save the nurse's back and shoulders a little bit. If we know baby is sitting low, especially if she needs to rest, knees together, ankles out, helps to open the outlet of the pelvis. And you can do that with a peanut ball too, between the ankles. Sometimes I've done this when we need to take a break during pushing, and I'll just kind of set her like this. Usually I would put a rolled up towel between the knees as well, so that that leg isn't hanging so much. And babies often really come down when it's like this, so we can kind of shorten that labor process a little bit. How about protecting the perineum for fewer tears? I'm always an advocate for spontaneous pushing if there's not an epidural in place. And often I have to counsel my clients that they just have to trust that their body is doing it. Some of them get in their head a little bit about that, and I don't know if this is working or not, but if their body is pushing spontaneously, more than likely it is. And if they need a little feedback, a nurse can check in there while she's pushing and let her know, hey, yeah, it's working, the baby's coming down, or maybe try this. If there is a heavy epidural in place, of course, the option is always there to pause it or turn it down if needed, so she can get some feeling back and some of her own feedback. As I mentioned before, flexible sacrum positions is going to help here too. Side kneeling or squatting. Try closed knee pushing, so knees out. Knees together, ankles out more. If baby is +2 or lower, it opens the outlet. Gentle perineal massage or hands off altogether for protecting that when baby's crowning there. Okay, hands-on support. Here's the third category. As you never know what people have been through in their life, I always say, always ask first before you touch hips or anything like that. Encourage family to participate or labor partners. This is where a nurse could offer some quick instructions on how to do counter pressure hip squeezes. Counter pressure, I always tell them aim for the booty crack, for the top of the booty crack if we're trying to figure out where to push. If a baby's high, maybe we want to push down a little lower. If a baby's low, maybe we want to push a little higher. But generally, for comfort measure, a mother will say where she wants it. She'll know you need to push higher, you need to push lower, lighten up a little bit, or you need to push harder. Often it's a lot harder. Love bum jiggles in labor. I generally tell my students that when we are doing holding things like counter pressure, hip squeezes, we do that through the contractions, and then we're jiggling stuff between contractions. So it's not too difficult for them to remember what to do when. But bum jiggles help all of those muscles down there to release and to relax. And it feels good. Who doesn't like a bum jiggle, right? Massages to the shoulders, hips, lower back also are great in labor. TENS units. I've had some moms use those. Put it on your lower back. It works great, just in different signals up there. Of course, like I mentioned, for ice packs or hot packs or shower wand to the lower back. It's whatever's going to make her feel better. Maybe it's getting her hair braided or having a head massage, something like that. So, Tiffany, I love that you showed your grandbaby, because here's my grandbaby in my slideshow. This baby is 3 weeks old today. That's my daughter-in-law and my son. She's a type 1 diabetic. She had her baby at USA Children's, managed to go through the whole induction without an insulin drip. And we were really, really proud of her, and her mother braided her hair during her labor as well. But she's kneeling at the foot of the bed. She was using the nitrous. That did help her get through until she got to the point where she needed the epidural. And that's my son doing some bum jiggles with her there. Wrapping it up, here's my 3 main categories in order of importance: environment, movement, and hands-on support. For the postpartum pain management, this was alluded to earlier, as well, as far as instructing what to expect and what is normal. You know, there's a lot of general soreness after having a baby. You kind of feel like you've been in a car wreck because your body's been through a lot. Might have some perineal or incision pain, afterbirth cramps. Those afterbirth cramps are pretty brutal if you've had more than one baby. So I always encourage my clients to ask what their standing orders are for their pain meds before I leave, so they know what the options are. And I always encourage trying the non-steroidal anti-inflammatories that are on order prior to going to anything stronger. I used to work mother baby years ago, and I remember patients would ask for pain meds, and some nurses would just go and grab the Tylox and take it right to them without even having a discussion, like, hey, would you like to try some ibuprofen first? This might work better. It's an anti-inflammatory. It's going to help with these things that are inflamed, right? But all the things that we use in labor to help that are non-pharmacological can help afterwards too. That slow breathing, we have to do that through some of those afterbirth cramps. Putting the music on, getting in the shower, maybe a hot pad for cramps. Ice packs, of course. Sitz baths. I don't feel like instructions are given enough on sitz baths for when they get home. Even just 10 minutes in a clean tub that has a few inches of warm water with a little salt in it is going to help that to heal up faster. Anybody remember Perry lights? I think there's some other people here who are old enough to remember Perry lights. For the younger people, I wish we still had them. It probably is a fire hazard. For the younger people, it was like a giant car cigarette lighter that you would put at the foot of the bed, and it would shine on your hoo-ha, and it felt fantastic. I had it after one of my babies, but it really helped to encourage things. I know can't do much about that now, but I thought that was funny. I've been thinking about Perry lights lately. As far as the breastfeeding goes and helping to cover all the pain that can be associated with that, I always tell them, those who have recently birthed, insist on asking for help. If you're having trouble getting your baby latched comfortably, if it hurts, that means they're not latched right. So now I know there's going to be some general nipple soreness that will happen, but if a baby is not latching well from the beginning, they have to ask for help. We have in our area here, Mobile and Baldwin County, we have, actually, I think we have a third one now, IBCLCs who work with Lactation Network to cover in-home lactation consultations for free. They get 6 visits covered by insurance, and they like to meet prenatally. So I encourage them to reach out prenatally so they kind of know what to expect. And this way too, they have someone already lined up. If they need help once they go home, they can come see them like the day after they get home and help with that latch. And of course, I'm a big fan of the skin to skin and encouraging time for the babies to breast crawl, waiting until they're really showing those good signs that they're interested in eating before trying to get them on, because they're going to do better as a result. And then I have my sources here as well. That national partnership work up there is one that has the right child rearing infographic that is really great. And that is it for me. Open to questions if anybody has any.
So much, Jennifer, for that. If y'all have questions, feel free to put them in the chat. I'm going to take over for Britta, who had been doing our MC work, and kind of close this out. But keep putting questions in the chat, and we'll also make sure you guys have Jennifer's information and Tiffany, Amanda's, and Judy's information if you guys have questions. And just to wrap up, I will say we are so appreciative of you guys joining. and are grateful that you guys spent the time to understand effective pain management in order to really support that recovery while reducing the unnecessary opioid exposure if we can, and continue to implement practical strategies within the hospitals. I wanted to kind of follow up and just mention this recording will be on the ALPQC website, along with in our clinical resources, there will be the sample orders that Thomas Hospital created for everyone to be able to use. Those will be on ALPQC's website under clinical resources, and as well as a handout around pain management techniques for families. So all of that will be online. And if you have other hospitals that may have said that they missed it and want to see it, this recording will be there. Please send them there, and feel free to watch again. Thank you guys for coming. We will see you next time. We do have a second webinar as part of this series that focuses on pain management, but for those with substance use disorder. So if you or anyone you know has questions on how to do great pain management during labor and delivery for those with substance use disorder, that will be on July, I'm going to say it wrong, July 16th at noon.
Yes.
So we hope to see you guys there.
And I just threw a survey in the chat if y'all would like to complete that. It's an evaluation of this webinar. I'll send the link out in other ways too if you don't grab that right now. Thank you.
Thank you.
Thank you.